Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and if you've ever looked at your family and thought, okay, who's the doctor for everyone here? Then this episode is going to be for you. Today, we're going to talk about Med-Peds at the Flormann Clinic with Monument Health. That's internal medicine and pediatrics under one roof with doctors who can see kids, teens, adults, and not someday, but right now. We're going to talk with Marissa Copas Weaver, Dr. Marissa Copas Weaver, and Dr. Eammon Grosek about why this model makes so much sense, especially if you're starting fresh with primary care or trying to simply care for your family. So this is about relationships, continuity, and finally not having to explain your health history from scratch every few years. So doctors, thank you very much for coming in and doing this. I appreciate it. And I guess to start the whole conversation today, we just need to know what Med-Peds is. I don't know a lot of people that have heard that term before. So if you could explain in the simplest real world sense, what is it?
Yeah, the easiest way to think about it is to think of it as we are both internal medicine physicians and pediatric physicians. So typically, when you get done with medical school, you go on to residency. That's where you really start to specialize. You kind of learn, what you're going to be doing as a physician. Internal medicine physicians go to residency for 3 years. Pediatric physicians go for 3 years. In Med-Peds, we basically spend 2 years as an internal medicine physician and 2 years as a pediatric physician. And so what that means is about every 4 months or so, you switch. And so for 4 months, you are an internal medicine physician. You basically do what the other residents do. You're held to the same standards. You see the same patients. But in addition, you have basically an outpatient clinic where you're seeing both adults and kids. And then after 4 months, you switch over to peds. And once again, you do what the pediatric residents do. You see the same patients, you're held to the same standard, and you continue to follow with your longitudinal patients, both adult and pediatric. So the easiest way is just to think of it as both and.
Oh, that's a great way to explain that. Well, Marissa, what brought you into this? Why did this appeal to you over just being an internal medicine doctor or a pediatric doctor? Because it just seems like more work. Right?
Well, some days. I actually thought I wanted to be a family medicine physician for a really long time. That's why I went to med school. And then I was on the pediatric floor in the hospital, and I really enjoyed it. And then I went to labor and delivery, and I love delivering babies, but not enough that I wanted to be on call for that. So I also really loved my time in the internal medicine group as well, and so I just couldn't pick between either specialty once I kind of ruled family medicine out. And then I realized that with during a residency in Med-Peds, I'd be specialized in both internal medicine and pediatrics, and that really kind of sold it for me.
Really? This is not I was talking a little bit with Eammon before we started the podcast. This, like I said, to me, I've never heard of this specialty. But apparently it's been around for a while. Is it new though to kind of Monument Health in Rapid City?
Yeah, so I actually applied to family medicine physician jobs when I applied to Monument, and then just said I'm actually a Med-Peds physician.
Okay.
And so they hired me into the internal medicine department because they didn't have a Med-Peds spot yet. But we've been blessed that Dr. Grosek and I have been able to kind of move into our own Med-Peds pod inside of the Flormann Clinic where we can do both of our specialties.
Do you see this as kind of the future of internal medicine when it comes to family practice? Or will there always be the need for pediatrics and the need for family internal the next step beyond pediatrics? Or do you think this blending will be something that might be the future?
So one of the things I do every year is I take a look at the match and I see where the USD med students are matching to. And for the 5 years I've done that, I think I've only seen 2 match into Med-Peds. It's not a very popular thing. The vast majority of physicians are still going to be internal medicine or pediatrics or family practice. We're kind of the exception, not the rule, I guess I would say.
Well, what we were talking about a little earlier too, and what I think is most interesting about this is a family brings their baby into you for you to see. And they're like, look, we want you to be our doctor, okay? Through this child's toddler years and teenage years and into adulthood. And as long as you're going to be here, you're going to be their doctor. And if conditions arise or situations come up where something happens to that baby or that child or that teenager, you are seeing it from the very beginning. You are seeing that condition develop. And to me, that seems like you have an advantage then to help this person throughout. Hopefully it's not a permanent thing, but it might be, right? It could be a condition that's not maybe life-threatening, but they're going to have to, like maybe a diabetic, right? Does that give you guys kind of a leg up on these people, on these patients then as well?
I feel like it does. With the specialization of our internal medicine residency and our pediatric residency and the combined, we are, we have that maybe more defined experience in like type 1 diabetes. And so then as we have more experience in the pediatric part of it, then when they cross over into adulthood, we then are like, we have that pediatric background. We're used to this type 1 diabetes, they're on the regimen. It's a much easier crossover to an adulthood. And then we kind of have a leg up on what screenings do we need to do now that they're adult, versus then someone who would go to a pediatric clinic and then have to go to an internal medicine clinic and start over.
Well, what is a day-to-day like for you guys then? When you get up, you get into your office, and it has to be very unique compared to what other doctors do because of the difference in patients that you're seeing. So what does that look like for you guys?
I don't think it's terribly different. I mean, I'm still seeing mostly adults. Hopefully I'll get more pediatric patients here soon. But yeah, there is definitely sometimes where you kind of have to do a 180. The way that you speak to like a 57-year-old and the way that you speak to a 5-year-old is very different. So I would say the biggest thing is kind of changing communication styles. And then also the focus of the visit can change a lot. Like, for example, child visits, it's all about that, preventive care, trying to anticipate things that'll come up. Adult care is all about trying to deal with the consequences of bad decisions that we all make. So yeah, there is a little bit of change in ethos, and you kind of have to switch gears a little bit, but it's still just one patient after another.
What's your patients like? Is it mostly kids, mostly adults? Do you have a mix right now?
I have a little bit of a mix. I'm seeing a lot of actually younger adults, and I'm slowly getting pediatric patients. I've been getting a lot of, their parent comes and see me, and I said, hey, by the way, I also do pediatrics, and then the kids will kind of trickle in from the parents. I've had a couple of newborns, which I love. Those are some of my absolute favorites, is just to get them when they're fresh and then watch them grow. But mostly more adults as the word gets out.
Well, I love the fact that the adults will come and see you. You tell them that if they have kids, you work with you have pediatric medicine as well, because then the adult gets to have even more of that conversation with you, right? I know when my son was growing up, we'd take him to Black Hills Peds. That's generally where they went, and I never felt though like, I mean, I could be there and ask the questions. I could sit in the room, but there still felt just a tiny little disconnect there. I'm like, well, if you were my doctor too, then that whole family history, that whole conversation we could have. And that must be a big benefit for you guys as you get further down the road with this. Would that make sense?
Yeah. So much of the troubles that we run into in pediatrics can be based on kind of like the environment. How are things going at home? So knowing both the adults and the children, gives you a more complete picture. And it's not uncommon that, like, let's say you're seeing the adult and they have a question about their kid, they could just add it on to the visit, super easy, or vice versa.
Does it make it I mean, when you have somebody come in to see you, if they have an appointment and, both parents come in and the kid's there, and all of a sudden you're doing the appointment for all three of them. I mean, that's not recommended, I would assume. But, they're obviously going to have the questions while they're sitting there, right? I mean, how do you handle stuff like that?
If it's a fairly benign
Right.
question, like maybe they are nervous to start a medication or nervous about taking their own Tylenol ibuprofen for something, then I'm more than happy to answer questions. If we do kind of start straying away into a lot of more complex questions, then I do recommend that they make an appointment. That way we can focus solely on them
Right.
and then not kind of take away from the child. I love well child checks. It's where you can sit down and focus completely on that child, and then you get the parents in and you see the social interactions, like Dr. Grosek said. And so, and then it's even better when the parents are also your patients, because then you also kind of understand like where they're coming from. And what I've noticed is when parents have concerns and their medical history because they're also your patient, that kind of helps
Oh,
with the way that you counsel them, and the way that I can say, well, your child is healthy and doesn't have signs of that. This is what to look for, and it kind of helps ease the parents' anxiety about it, because then not only are we're mentioning about the child, but I can also ease their anxiety about it as well.
well, and I've noticed in doing these doc talks over the years that we've done, I'm talking with a lot of doctors, and one thing that is very important is sitting down and actually being able to listen to what your patient is saying. Not like, oh, I've got 10 minutes with you, I got to get you in, get you out, because of what's coming up next. And it seems like that is a big benefit to patients. And you're just kind of adding on to that as like, look, if I know your family history, because you're also my patient, then the outcomes we're going to have with your kids and what we can look for and stop maybe in the future, that's invaluable, right?
Yeah, there've been a lot of studies looking at, patients who have primary care versus those who do not have it. And most of them show that, even when we factor out things like socioeconomic status, just having someone who's kind of longitudinally following with you long term, someone who's on your side, who kind of knows you, knows your values, generally is associated with better outcomes. And I suppose that we're in a unique position where we can do it for, the whole family.
Right. Um, well, what's something unique with what you guys do that you feel patients just might not get anywhere else? Is there is there that uniqueness there that you're like, well, here's what I offer you that you might not be able to get with one or the other?
Yeah, I think that we're in a very good position for handling. The way I like to put it is either kids with adult illnesses or adults with kids illnesses. So we're basically seeing a lot more survival as medicine is advancing. So, like for example, cystic fibrosis, a lot of those patients are living into adulthood that never did before. We're really good for patients who have cystic fibrosis because, my experience is that we've followed them from, the hospital when they're younger, and then that just kind of gives us more information when they're older. Congenital heart disease is another one. Those patients are living longer. Cancer survivors, like survivors of childhood cancer, that's another group where, yeah, they're living a lot longer than they used to. There's a lot more of these patients out there, and just our unique perspective allows us to know what they went through, what happened, and it gives us a better ability to know what to do next.
If there are, adults listening right now to the podcast, why might something like Med-Peds still be the right choice for them if they haven't made a decision yet?
I feel like it just kind of goes back, I think, to our training. Like, we are combined physicians. We have the specific training in internal medicine and the pediatrics. I don't know about you, Dr. Grosek, but my clinics were actually split. Had an internal medicine clinic where we did it was quality over quantity for patient visits, and we really sat down and went through each patient with like my attendings, my faculty, and we're very diligent about going through every single thing. And there was a lot of a lot of good teaching involved. And then we went to our pediatric clinic and had like that same experience. And so I think one of the benefits from that is there wasn't a lot of overlap in the clinic. So when I was there, I wasn't like juggling a 4-month well child check and then a Medicare wellness visit. So we were able to focus more deep down in the details individually. And then I can take that in now to my clinic. And with, having the experience of residency, it's way easy to just juggle between the two because I had that deep experience
Right.
in residency.
Is that how you feel too, Eammon?
My training our clinic was both adults and peds at the same time. But I mean, like I said earlier, you kind of put on a different hat when you switch between adults and peds. But like getting back to the question, why would an adult choose Med-Peds? I mean, going back to my earlier answer, we are internal medicine trained.
Mhm.
We took the internal med boards. We're kind of held up to the same standards. I do feel that kind of a focus on basically the social determinants of health is something that's more emphasized in pediatrics. So even in adults, I think we talk more about kind of those things in your life that might need fixing, but we're not going to throw a drug at. Just kind of more of like a whole picture kind of approach to health. So I think that's one advantage when it comes to seeing adult patients as a Med-Peds.
I suppose too, talking about all the benefits and all the reasons why, there's probably, it's helpful to know what you don't do too. Like, so let's talk boundaries here a little bit, okay? What's kind of outside of the scope of Med-Peds? And why is it actually a good thing that some of these are outside of that scope? Are there some things?
Obstetrics.
Yeah.
Okay.
The big one. That's the big one.
Why is that?
I mean, it just doesn't fall under the umbrella. A lot of obstetrics is, and this kind of gets to a bigger picture. A lot of obstetrics is very procedure based. I mean, ultimately, it's going to be a procedure, the birth. Family practice has a lot more experience with procedures. At least when I was in med school in Sioux Falls, I knew of a couple family practice residents that were spending time with general surgeons. There was even one learning how to do colonoscopies, which I thought was kind of cool. But yeah, family practice just spends a lot more time on procedures. They spend a lot more time on obstetrics. They can do things like ingrown toenails. We don't do things like that. But I guess the biggest advantage of not doing obstetrics is that it gives us more time to learn about everything else.
Is that kind of how you feel too?
Yeah, I mostly just didn't want to be on call for
Yeah.
obstetrics.
Well, that's grueling, right? That totally can be, you've got to be super. I mean, not that you guys aren't super dedicated, but that's a whole other, that's just a whole other ball game, really. Now, if someone doesn't currently have a primary care provider or wants one clinic for most of their family, what is the one thing you would want them to know more than anything?
Well, like I was saying earlier, just having a primary care physician, a lot of patients may feel like they don't need it. They're like, I don't have any health problems right now. But there's a lot of anticipatory things we can be doing. There's a lot of monitoring we can be doing. And like I said, sometimes it's just very reassuring to know that you have someone who knows you. So if something weird does come up, you can go to the physician and we could tell you like, no, that's nothing to be worried about, or that is something to be worried about. And like I said, outcomes for people who have primary care physicians are just better, even when we factor out things like, income or position or anything like that. So there's a lot of anticipatory guidance that we can offer.
Right. How do they take the first step then? What do you guys, how do you encourage somebody to get into the clinic, to get a doctor that they can trust?
I think you just
I mean, it's not like you go on a streetcar and be like, look, I'm a trustful doctor. All right, come see me. But people listening to this will be like, well, I like what they say. I like this whole idea, but I don't know, like how do I start? How do I take that first step? Because there are still people that do worry about the economics of it. There are people that worry about, what if the condition that I have, they just, they're not going to understand this. They're not going to, you guys will. And most importantly, I think it's just listening, isn't it? I mean, and you just want to get people to give you that call to be like, hey, just let's talk. And then let's see first.
Yeah, you mentioned the trust thing, and that was just from had a little flashback. No, one of the reasons I became a physician was because I wanted to be a provider that patients trusted. And so that literally was my entire
basis for getting
personal essay. And so really, there is a thing, for doctor shopping. I think with primary care, the most important thing is to be able to find a physician that I'm a millennial, vibe with, and that you feel like you can trust, you feel like they sit and answer your questions. And I think if you like come in and you see someone and you don't like it, it's okay to switch to someone else. And I think some people are afraid that the person they see, they're going to be stuck with.
Right.
And I just want to remind people that look doctors up. Like they, especially a Monument, they have all of our pictures and have a little bio, and if you come in and you feel like it's not the right fit, that's okay. That doesn't mean don't try again.
Right.
It just means keep going until both you and the provider feel like it's the right fit and you just feel comfortable talking to them.
Yeah, it's funny how sometimes patients are like, "Oh, I'm so sorry. I'm gonna switch providers," and I'm like, "No, you go with whoever you feel that you're best treated by, right? I want you to feel comfortable. I don't take it personally when a patient switches physicians. So if you just don't feel comfortable, and a lot of that is, things that we can't put into words. You just don't feel that connection. That's understandable. And like let's say the physician just doesn't hold the same values that you hold, and you want someone different. That's fine. That's fine. At the end of the day, I want you to get what you need, from whoever's going to provide you the best care. So I don't take it personally.
Well, that's about the best way to wrap this up, honestly. That was about perfect. Was there something else you wanted to add, though?
I've had several patients come in who are like, I feel like maybe I'm too much for you, or I feel like you're not going to understand what's happening to me. And internists, specifically internists, love to read journal articles and love to learn. And so I always say, if I don't know the answer right in this very moment, that doesn't mean I won't figure it out, or I won't talk
That's
to
so good to hear.
a colleague about what's going on, or reach out to a specialist. So if they have concerns and they're like, I never felt like someone understood it before, that shouldn't be a deterrent, because someone will listen.
Excellent. Dr. Marissa Copas Weaver and Dr. Eammon Grosek, thank you guys for coming in and talking. And I encourage people to look up the Med-Peds for your entire family. It's refreshing and it's reassuring to know that this exists. And for a lot of people too, it's a time thing. Look, I can go to one doctor. I can take my entire family there. I don't have to split it amongst, pediatricians, internal medicine, which they're still great, don't get me wrong, but one stop and you guys get taken care of. So thank you very much for coming in and talking with me. I appreciate it.
Yeah, thank you.
Thank you very much.